So this is kind of an interesting thing, just like, what's going on with the treatment of metastatic spine disease. I think there's been a lot of changes in the course of my surgical career. And it's kind of interesting. And each one of these elements can really be, an hour plus discussion in and of themselves. So just a little bit of the demographics, 1.2 million Americans are diagnosed with cancer yearly. There's 600,000 bone mets, 2,700 primary bone sarcomas, and 20 to 40% of cancer patients will develop spinal mets. About 20 of these will be symptomatic with cord compression. The spine is the most common site of bony mets. Spinal mets develop in 5 to 10% of patients with cancer, 90% with prostate, 75% with breast, 45% with lung, and 30% with renal. 40% of dying cancer patients have evidence of spinal mets on autopsy. 10 to 20% of patients with spinal mets will have neurologic deficits, and there are approximately 25,000 new cases of cord compression every year for mets, and that number is estimated to grow. And I think it's important to look back before we talk about where the future is, because clearly, and some of us more senior people, we can recall the days based on, what tools were available at that time. And in 1979, Peter Black at the Brigham made the following recommendation that radiotherapy alone should in general be the primary treatment for spinal mets. And radiotherapy seemed to be superior to surgical decompression alone and is equally effective as a combination of surgery and radiotherapy. And that sort of set the stage for, the 80s with how we would take care of spinal tumors. And it was really based on this because at that time, what surgical techniques were really available, and it was laminectomies. And so when they looked at laminectomies in the setting of, spinal mets, they failed, right? They didn't have neurologic improvement. They had, no relief of pain. And then, when you looked at, this with radiation therapy, radiation had really become the preferred method based on sort of these metrics. And logistically, it makes sense because if you take somebody who's basically unstable, right, they're going to be prone to failure because the pathology is predominantly anterior. So laminectomies don't do anything to offer anterior decompression. And patients oftentimes present with tumor-related deformity. Patients have neuromuscular instability, so they're prone to progressive deformity, and removal of the posterior osseous and ligamentous structure further imparts, biomechanical instability. So, based on the techniques available at that time, it really made sense. Bridging into, the early 80s, there was sort of this, renaissance of surgical techniques that were subsequently employed. And in 1982, Sundaresan, published a technique where they, did an anterior corpectomy, and then they reconstructed this with using a chest tube and Steinman pins in PMMA. And this allowed surgeons to kind of circumferentially decompress the cord and give them anterior column support. And this was really considered sort of the new age of approach. And then with sort of the, introduction of pedicle screws and so forth, it gave surgeons, a little bit more in their armamentarium to treat things. This is another paper from the 80s, the late 80s, and it was a review of over 70 articles and 2,000 patients treated for spinal mets. And there were, 60 to 90% improvement in pain relief and 55 to 97% improvement in neurologic outcomes after anterior decompression and stabilization. So the tides then began to shift, away from radiation as being the primary treatment, and looking at maybe surgery is the way to go. And this is really kind of one of the seminal articles in spinal metastasis. And this is the Patchell paper from 2005. And so this was a study that was started and was stopped because of it. It was shown that, the surgical arm, performed far much better than the radiation arm. And so in this study, they had, paired cohorts of 51 and 50 patients, and they were treated as follows with surgery: anterior 28, lateral 9, and posterior 13. When you look at the Kaplan-Meier curve, and the heavy line up top is the surgery arm, and the one below is the radiation. So what they discovered with surgery, patients had, longevity, right? They lived twice as long as the patients without surgery. And when you broke it down and you looked at the following, the maintenance of urinary and fecal continence, 17 days versus 156, maintenance of ASIA score, 72 days versus 566, maintenance of Frankel score, 70 days, 566, and survival time, 100 days and 126 days. It was clear that, aggressive treatment of patients with, metastatic cord compression did far better with surgery than radiation alone. And that was the consensus statement with this. And this really shifted sort of, how we approach treating, patients with METs at that point. When you looked at, 62% of patients regained their ability to walk, that's pretty astounding. And it's given sort of the modern surgical technique, pedicle screws and circumferential decompression. So when you look at where things are today, it's like, I think there have been various leaps and bounds. And in this Bilski paper published in 2018, they really kind of summarized, where the field is and how, centers are actually dealing with these patients. And, he's chief at Sloan Kettering. And so basically, the goals for treatment are preservation or restoration of neurologic function, improve pain control, health-related quality of life measures, maintenance of spinal stability, and obtaining durable local tumor control. And so this is kind of, when we look at what have been the major advances in helping us treat these patients, I think far and above all others, stereotactic radiosurgery really has been the game changer and has shifted the tides yet again. And I'll get into that a little bit more. And then introduction of less invasive surgical techniques using separation surgery, minimal access techniques, PERC instrumentation, cement augmentation, all of these in combination are huge advancements compared to where things were, early in the 2000s. And then also redefining spinal instability. Previous to, the SIMS paper, it was a lot of just postulation. And then, development of all these new biotherapies and immunotherapies are also, major changes in how we can treat, spinal METs. And so, what they put together is the NOMS framework, and I'm sure everyone's familiar with it, and I'll go over it in some detail. And so it breaks it up into 4 pillars, and it's neurologic, oncologic, mechanical stability, and systemic. So neurologic, it's based on, is there cord compression? So there's a scale for that in the presence or absence of myelopathy. From oncologic, are we dealing with radiosensitive tumors? And will we employ stereotactic radiosurgery or conventional external beam radiotherapy? And then in terms of the mechanical stability, is using the SINS classification system. And then systemic is, giving what are we using for prognostication and the patient's ability to tolerate surgery, as well as, the genetic analysis of the lesions and, what sort of molecular therapies can be employed. And so this is the decision tree, and I'll refer back to this after every one of the subtopics here, but it's actually quite interesting, to look at sort of a low-grade compression without myelopathy, and then determining from there, is it a radiosensitive or radio-resistant surgery? Are they mechanically stable or unstable? And then using these as branch points in the decision tree to define whether they should get external beam treatment, stabilization by external beam, should they get just stereotactic radiosurgery or stabilization followed by radiosurgery. And then those patients with like a high-grade cord compression plus or minus myelopathy, again, sort of using this decision-making tree. And here we'll consider, are they able to tolerate surgery or unable to tolerate surgery? And then employing, external beam, stabilization by external beam, or radiosurgery or a combination thereof. So it's actually, I think, this is, again, far beyond the methods that we were using before. So with the neurologic portion of this, the scale that's used is a 6-point scale, and it'll look at sort of tumor encroachment on the thecal sac and spinal cord. And based on, the lower grade 0 through 1C, there's advancement of the tumor from the body, into the canal. And then with a 1C, there's deformation of the canal with cord abutment, but without compression. And then the high grade lesions, there's, cord compression, with CSF fluid still visible, and with a grade 3, there's compression with no no CSF visible around the cord. And so by using this, again, this is a major branch of the decision-making tree. So, the ones with grade 2 and 3, we consider high grade compression. And so when we consider this over here, then we, move on to the next phase of this, and that's considering if it's radiosensitive or radio-resistant, and then walking further down the chain to determine, is the patient able to tolerate surgery, and then picking the radiation modality. So from an oncological point of view, when we look back, we've been using, external beam radiation therapy for decades, and this is usually giving, like a certain dose of radiation, generally 30 plus gray and 10 fractions, and 1 to 2 beams deliver the therapy. However, one of the main issues with this are the organs at risk. So you're basically blasting the lesion and everything in between. It doesn't, we're blasting spinal cord, we're blasting, vessels, skin, and everything. And this is why there's such a high incidence of wound failure, after radiation. And we look at, what are the radiosensitive lesions versus the radio-resistant lesions. And not surprisingly, renal cell and non-small cell, some of the things that, metastasize more frequently to the spine are radio-resistant. So these aren't very helpful. And this, again, I think was probably the biggest game changer in treatment, I think, in the past number of years, and that is, the employment of stereotactic radiosurgery. And so this allows, the oncologist and the radiation oncologist to give a high dose of radiation per fraction greater than 10 gray. And this leads to not only breakage of the double-strand DNA, but also causes damage to the tumor vasculature. And so just a little bit on this, Lars Laxell was the first to coin the term radiosurgery back in the 50s. And the basis of this is you're using radiation from multiple points, and you're able to focus it in a very small area down to like a millimeter specificity. And at that point, this was used predominantly for cranial things with the Gamma knife. So it involved, the head getting put into a frame, and they had the patient be moved around at various time points once the radiation had been delivered. Nowadays, the patient remains sort of fixed, and there's a robotic arm that will sort of move around the patient, delivering, the fractions at various points to hit the target and minimize, the organs at risk. And there's, dozens and dozens and dozens of papers sort of looking at the efficacy of giving stereotactic radiosurgery for spine tumors. And basically, the consensus is it's safe to use. You can deliver high dose radiation, and you can also use it to re-irradiate areas that had been treated before with external beam radiation. Some of the contraindications, and these are even sort of being lifted at this point, are severe deficit due to cord compression. So that would be somebody that you wouldn't want to treat first, spinal instability. And then if somebody had received a maximal dose of radiation previously to, neural structures within the field, or if there's a neural deficit due to bone compression. And a lot of these are being rethought at this point as well, now that we have other treatment modalities for surgery. And when we look at sort of the local control of tumor with these over multiple studies, It's actually pretty astounding. And, when we look at over how many months you're getting control. So again, I think the stereotactic radiosurgery has been by far, one of the biggest, I think, boons in like spinal oncology. And this is just a case looking at an elderly lady with metastatic adeno. And you can see in the picture here on the bottom how the radiation oncologist is able to contour the beams such that we are giving minimal dosage to the spinal cord and working around it circumferentially by using these sort of stereotactic pinpoints. So separation surgery refers to, going in and decompressing the thecal sac by limited tumor resection, followed by stabilization, and then giving radiation afterwards. And this has been shown to be, quite successful in patients with, halting local tumor progression, after radiosurgery. So you're basically taking care of the cord compression and then radiating the rest of it. And going back to our decision-making tree again, looking at mechanical stability. So this paper's been out for, I think, about 5 years now. And this was a Zia and Felling's work of art. And it was actually coming up with a grading system for, radiation oncologists to use to determine if there's stability or instability. And this has a CAPA score of greater than 80 for inter-rater reliability. And we'll get into the elements of this here. So first of all, we look at location. And so is this a junctional area, which is going to tend to be highly unstable? Is it more in a mobile part of the spine, such as the cervical and lumbar segments? Is it a semi-rigid or is it a rigid segment? And you'll receive a score for that. And is there pain? So does the patient have pain relief upon lying down? Do they have increased pain upon standing up? And it's scored that way. And then looking at the lesion itself, is it lytic? Is it mixed lytic blastic, or is it just blastic in nature? And then what about alignment? Is there subluxation, translation? Is there a new kyphosis or scoliosis? What percentage of the vertebral body is collapsed, greater than 50, less than 50? No collapse with greater than 50% of the body involved. And in the last category is there posterior lateral involvement of the spinal elements? And we get a score from that. And so based on, what that tallies up to, patients are considered stable, potentially unstable, or unstable. And from there, we would consider doing, looking back at our decision-making tree and offering some sort of stabilization procedure. And so when we look at some of the advances that we have in our surgical armamentarium, I think separation surgery was a huge benefit to treating these patients using a posterior lateral approach, permitting decompression, circumferential decompression and stabilization. And then, the employment of minimally invasive techniques with, mini open, perk screws, tubular type retractor-based decompressions and cement augmentation. And it's interesting, because our current residents and fellows that are coming through now, they've only grown up in the era of having, these techniques. Just sort of like a cell phone. My kids have never really known life without a cell phone. So, things that, like those of us who've been in practice, these have been actually quite game-changing things in all of our individual practices, and definitely in the field of spinal oncology. I think another thing which wasn't mentioned, which I think is useful, is sort of looking at some of the carbon fiber implants, so you don't have all of the metallic artifact on follow-up images, and it allows the radiation oncologist to more accurately assess, tumor development or regression. Looking at the last portion of this, and that's the systemic, and is the patient able to tolerate surgery or not? And in the past, we've used the Tokahashi and the Tomita scores, and there's been some comparative studies looking at which one is better and so forth, and that has really been sort of a make it or break it for how we've looked at surgery. But even these scores have been considered and are questionable at this point, and their reliability is uncertain. Now, the skeletal oncology group has come up with a nomogram and actually using machine learning to come up with a more specific way to determine who is stable for surgery. And it's looking at, a number of things: hemoglobin, white cell count, age, previous systemic therapy, visceral brain mets, how many spinal segments there are, primary tumor type, and an ECOG performance scale, and then sort of giving an understanding of 30-day, 90-day, and 1-year survival rates based on those scores. And they're doing this off of, advanced analytics and machine learning. And then the last part of the S for systemic, and really, like, I'm by no means an expert on this, and it's very interesting just to kind of listen to my neurosurgical colleagues that take care of primary brain tumors and mets to the brain, just like how this portion of the field has grown in leaps and bounds with vaccine-based treatments that are patient-specific, employment of like immune checkpoint inhibitors and receptor tyrosine kinase treatments. This whole genetic and epigenetic portion of the oncology field, has just really, been growing at sort of like an avalanche rate in the past, decade plus. It's impressive to see what's going on. And I think this, if we ever wanted, we could maybe have one of the oncologists come and give a talk about some of the treatments, because it's definitely very intriguing. So, in this, review and summary, they concluded that, surgery is still particularly important for those with high-grade cord compression, necessitating separation of the epidural tumor from the spinal cord, but also for stabilization, facilitated by the SIN score. And then all of the, new techniques that we have and we're using, also help to minimize, the morbidity of surgery. And above all else, integration of stereotactic radiosurgery for treating the patients afterwards, and achieving durable tumor control. And I think the horizon still remaining some of these targeted therapies and so forth. So when we look at sort of the past 30, 40 years of treatment within our sort of medical lifetimes, I think treatment of these tumors has really gone full circle from, external beam is the best to, surgery is better to now, looking at sort of the combination of all of our, new techniques and stereotactic radiosurgery, and then even looking to the future and looking at sort of, how can we maybe do some sort of brachytherapy intraoperatively to help with the radiation afterwards. I think it's really kind of overwhelming from an intellectual standpoint, the advances that have been made from so many fronts. And just looking back at this again, so I don't know if you guys are using this with your tumor board at Scripps. I know we are at the university, and it's really treating these lesions is a multi-specialty approach, and we definitely play a huge part in it as helping out with our oncology colleagues. And that's all I got to say.
That's awesome, Don.
Yeah, it's great, dude. Appreciate it. Hanny, have you been part of the tumor board at all?
I have, and the answer is yes, we are using it now, but it wasn't something that I don't know if they knew about it, but we just weren't using it in practice. It seems like it's sort of surgeon driven, and that's probably because when somebody has epidural disease or a new neurologic deficit, you're kind of the one that's in the driver's seat in terms of making the decision, and so I think that we as surgeons, one, I think it's incumbent upon us to educate ourselves on that framework. And then two, I think that oftentimes we are put in a position to make the decision. And oftentimes the radiologist will defer. So it's important to kind of have the knowledge of what's possible with radiology, because it's often you, not the radiologist, that's making the decision, particularly if it's a Saturday or, during the evening time, something like that, and knowing what's radiosensitive and what's not. And the only other thing I would add, Don, is like, and I think you alluded to this, it was so nice when they came out with the NOMS criteria, because I think it was like a PGY3 or a PGY4, but we'd get all these patients, and like, depending on who was on call that night, we'd try to figure out whether or not we are going to radiate or not. Or it was just such like a non, algorithmic or non-specific way to treat them. And then they released that NOMS criteria, or at least became popularized. And as trainees, we had a much clearer sense of how to manage these patients and how to make these decisions, and had some like objective data points.
Yeah, absolutely. And again, I think the other thing is like, now with all the advances in the stereotactic radiosurgery, I think there's going to be a further shift in the near future where we have to actually operate on less and less, or maybe do, cement augmentation with radiosurgery. So it's really interesting. Again, I mean, like when we started, like, what you'd have to do. And again, you're a junior resident hit in the middle of the night because somebody comes in with cord compression, and not really having, sort of a roadmap of how to treat these patients. But now, like, I think, application of the NOMS criteria, I think it really is going to help our patients in the long run.
Totally.
Awesome. Yeah, it's interesting to see, even like in a lot of us on this call haven't had a very long career, but even how this has dramatically shifted over the last 10 years is pretty cool to see. And I know a lot of these guys are just working really hard to find less and less invasive ways to help these tumor patients, and I think we're getting there. It's cool to see happen. Yeah,
definitely. I mean, and just like things that we just leaned on before, like the Takahashi or Tomita scores as sort of a driver, now we can be a lot more specific of who we're going to offer surgery to. So.
I see Rob's gone. Dan or Tommy, do you guys have any other questions or?
No, I think it was a great talk, and it's like a super fast moving field and been a lot of changes. So I felt like throughout my training, it was really hard to keep track of, all of the new classifications and ways to categorize these things and how to think about them. But I think that having a clear framework is becoming a little bit easier now than it was. But that's really all I have to add.
Yeah, and it really underscores that, treatment of these patients is multidisciplinary.
Yeah.
Oh, totally.
It has to be.
Hey, Fernando, just out of curiosity, what's going on in Mexico with these kind of patients?
The NOMS, in the sense, they're slowly but gradually picking up on the community, but the technology is not. So the way the algorithm to classify and to treat, it's getting to the country, but not the technology yet. So we're still a little bit more old fashioned and more conservative in a way.
And it becomes interesting because that whole sort of algorithm falls apart if a community doesn't have stereotactic radiosurgery available to them.
Yeah, exactly. That's the thing. But I mean, it's still good to have all the algorithms and know what options are, because some patients that really need it, you can obviously take them to the States or just call a colleague and see what other options you have available, and not just do like a random treatment based on only experience and now on evidence.